Welcome back to REBELcast. I'm your host, Salim Rizai, and this is episode 121. And today we're going to be talking about the Battle of the Blades, video laryngoscopy versus direct laryngoscopy, specifically in relation to the device trial. Now, many of us know there's been this ongoing debate whether we should be using video laryngoscopy or direct laryngoscopy as our first choice for successful first pass intubation. There's a huge debate in the airway community, and you have to go no further than social media to see the back and forth on this. But today we're going to talk about a recent trial that got published, the device trial, and which one is actually better for first pass success. But before I get too far into that, let me introduce not one, but two people that are going to help me with this paper who did pretty much the entire write-up of this paper. Marco Propersi and Will Smith. Guys, Marco, why don't you start? Tell us a little bit about yourself, where you work, what you do, and then Will, why don't you follow up and let us know as well?
Hey folks, it's Marco Propersi here. I am Vice Chair of Emergency Medicine and Assistant Program Director at New Vance Hospital in Poughkeepsie, and I'm also Associate Editor of Rebel EM.
Hey guys, my name's Will. I just graduated as a resident. Dr. Propersi was actually one of my attendings up in New York, and now I'm back where it all started in Northern California, where I used to work as a tech and kind of got the itch to go to medical school.
Thank you guys for taking the time to do this. I know we were working on our crazy schedules and finally found a time that worked for all of us. Will, why don't you start us off? What's the paper that we're going to be covering today?
So this paper was written by Precker, Driver, Trent et al. It's video versus direct laryngoscopy for tracheal intubation of critically ill patients. It looks like it was published in New England Journal of Medicine, June 16th, 2023.
And Marco, what's the clinical question these authors were trying to answer?
Salim, the authors were trying to determine in critically ill patients, does the use of video laryngoscopy compared to direct laryngoscopy improve first pass success rate of intubation?
And Will, can you just briefly tell us a little bit about what these authors did?
Yeah, so this was a pragmatic, multi-center, unblinded, randomized, parallel group trial that combined both video and direct laryngoscopy for tracheal intubation in critical patients. There were a total of 11 medical centers throughout the U.S., just over 1,400 patients from 17 different sites, including about 10 ICU locations, as well as 7 emergency departments. And the trial was registered on clinicaltrials.gov.
Perfect. And so they included basically adults that were aged greater than or equal to 18 years of age, undergoing orotracheal intubation, and located in a participating unit. Exclusion criteria I'll list in the show notes. And Marco, let's talk about the primary outcome. What was the primary outcome of this paper?
The primary outcome was successful intubation on the first attempt. The authors defined the primary outcome as the correct placement of endotracheal tube with a single insertion of the laryngoscope blade and endotracheal tube or a bougie.
I'm glad they defined that because it seems like different trials define first pass success in different ways. And we'll talk a little bit more about that when we get into the discussion. Now, Marco, what were some of the key secondary outcomes that we're going to cover today?
So secondary outcomes included severe complications of tracheal intubation. And this is important because this is a composite, and they defined it as one or more of the following, which had to occur within 2 minutes after successful intubation. And they included severe hypoxemia, which was pulse oximeter reading less than 80%, severe hypotension with a systolic blood pressure less than 65, cardiac arrest not resulting in death within 1 hour, or cardiac arrest resulting in death within 1 hour.
And we'll list all the exploratory outcomes in the show notes. There was a ton of them and too much to bore the listener with, but they'll all be listed there. Now, Will, let's start with the population when we get into the results here. So can you tell us a little bit about this population we're about to evaluate this paper on?
Yeah, so there was a total of 1,420 patients that were enrolled. around the same amount were included in the primary analysis. About 705 were randomly drew the video laryngoscopy, whereas the cohort of the direct intubations was about 710. The most common indications for intubation were altered mental status, and that was around 45%. And then the next most common would be respiratory failure, which was around 30%. Around 70% were intubated in the emergency department, which we'll talk about this more obviously, but it does make it a little more applicable to emergency medicine. And then typically the people doing the intubations were either residents. Now it didn't specify whether this was a first year resident or some of the 4-year programs out there, but it was mostly either EM residents or it was critical care fellows. And I think that makes up about 90% of the people, the operators here. And then the operators typically had around 50 intubations worth of experience, and that ranged from anywhere from 25 to around 90. Was kind of the range there. Previous intubation, so now this is talking around the ones that we kind of centered around 50. Almost 70% of those had been done video laryngoscopy. So a lot of the background from the learners coming in or the operators was primarily video. But that didn't necessarily change the one-to-one, whether they were going direct or video.
Yeah, so pretty much these were easy intubations for the most part, done by trainees is basically what I'm gathering from what you spelled out. Now, Marco, let's talk about this primary outcome, first pass success. Was there a difference between the two groups?
Yeah, so actually the investigators found for first pass success, there was a statistically significant difference among the two groups. And actually in the video laryngoscopy group, they found that that first pass success rate was 85%. And it was just 70% in the direct laryngoscopy group. Now, that's huge. That's an absolute risk difference of 14%.
And what about any of the key secondary outcomes? Was there a difference between the two groups?
Yeah, 151 patients in the video laryngoscopy group, which is about 21%, and 20% of the patients in the direct laryngoscopy group met the secondary outcome. There was a very small absolute risk difference that did not reach statistical significance.
And to remind listeners, severe complications during intubation was that secondary outcome. Now, when we talk about the exploratory outcomes, I'm just going to list a few of them here, but successful intubation on first attempt without severe complications. There was a trend toward video laryngoscopy being better than direct laryngoscopy, 68.7% versus 59%. Failure to intubate the trachea due to inadequate view was 3.7% in video laryngoscopy and 17.3% in direct laryngoscopy. And if we look at the median time to intubation, video laryngoscopy was 38 seconds, direct laryngoscopy was 46 seconds. So let's get into some of these strengths and limitations, guys. So Marco, let's start with you. So obviously this study addresses a clinically relevant and heavily debated question. Were the patient groups balanced at baseline?
Yeah, if you look at Table 1 in almost all these trials, these are all the demographic information. And what we find is that the randomization process was actually sound, and it appears that based on the demographics, that the patients have the same prognosis in each group. So I thought the balancing was pretty sound.
Awesome. And then I really like the inclusion criteria being broad. It allowed for a diverse patient population to be included. And that's basically what we do in the emergency department, right? We see everyone and everything all the time. So I like that they didn't wean this down to like a niche population. They just took all comers. The other thing that really kind of leads us to believing in that primary outcome is they did multiple sensitivity analyses, and they accounted for factors such as trial site, protocol violations, missing data, and additional analyses. And they found that there was no difference in any of those groups, regardless of what you did, VL or DL. So that really kind of adds a lot of validity to that primary outcome. Now, Will, when we get to the limitations, one of the issues that I've seen come up on social media and that we brought up as we were reviewing this paper was that most facilities were teaching hospitals. So can you elaborate on that a little bit more?
Yeah, so like we had said, that most of these, almost 90%, were either residents or they were fellows. So still very much a younger crowd. Like the average intubations was only like 50 total intubations. So not a ton of experience. Most of these people had experience on video laryngoscopy. So kind of already going into this, regardless of which direction they were supposed to be going with direct or video, most of their experience was already in that video setting.
Yeah, they already don't have a lot of experience doing intubations, and most of the experience that they did have was with video laryngoscopy, which is going to bias the trial toward favoring video laryngoscopy. Now, the other issue I had with this paper, Will, was what about like the modes of oxygenation? What types of meds do they use for induction and paralytics? Do we have any good information on that?
No, I mean, they did say that I think that there was an area that talked about pre-oxygenation, but I didn't remember seeing anything that specifically says what induction medications they used, or had there been any attempts like other time, like they had already gotten stuff by the time they got to the hospital or anything like that. So some of that can still be a bit of a question mark and make it a little more difficult on your first pass.
Okay, Marco, the trial got stopped a little prematurely. What does that do with the outcomes that we're talking about?
Yeah, whenever I see this specifically with pharmaceutical studies, which this was not, but it's a giant red flag for me. We always have to be cautious about trials stopped early for benefit. Most often, what we see is that there would be regression to the mean, and many of these data and these findings would actually potentially be washed away if the trial had been able to be concluded to completion. One of the good things here is that they actually had a priori stop criteria. So they had predetermined stopped criteria, which they decided upon before the trial began, and which they met on interim analysis. So this is not quite the same level that you see in these pharma companies.
Got it. And then what about the type of blade in terms of geometry that was being used in this study? Because we haven't mentioned that yet. And I think that that's a really important point to bring up.
Yeah, I remember, I mean, I'm going back about more than 15 years. I started residency in 2008. And I mean, we really didn't even have video at my residency shop, but we had all this talk on Mack and Miller. And by the time I graduated is when we first started with glide scopes. And then there was standard geometry and hyperangulated, but they actually didn't mention and they didn't require any specific blade geometry. So they left that up to the user to determine what type of blade geometry they want, which is actually pragmatic. But what we found is most of these blades were standard geometry. So it's going to limit the generalizability to other different types of blades.
Now, Will, you had already mentioned that the majority of intubations, 90% of them were performed by emergency medicine residents and critical care fellows. Now, what do you think this does for people that have more experience? Do you think that this study applies to people who, like, for example, when I started residency, I trained in DL. The first 3 years I did residency, I did a combined EM-IM residency. The last 2 years is kind of when video laryngoscopy got introduced. And then I started learning on video laryngoscopy. So I kind of learned backwards. But obviously, by the time these studies are coming out, I now have experience with both DL and VL.
Yeah, I think that that's a good point. I think that a lot of the modern training is most with video. And, you know, also it's the, like you say, it's the time you train. I know I just recently got out of training, but I think I'm even going to have a different experience than, you know, my future, the residents going through my program now, because I went through COVID. So I probably, by the end of my first year, I probably had close to 75 intubations. So I was very, very comfortable with that. But, and I think it mentioned this in the article, that I was also kind of not expected to do video, but it was promoted that I do video because it actually keeps you further away from the airway and your face isn't always in there, right? With direct, you have to be able to be quite a bit closer to the patient than you do with video. And even with that said, at my shop, our video was typically the hyperangulated blade, which this study kind of doesn't really suggest. It says the natural geometry blade. And then when I think we had a CMAC and when it was actually working, we would actually like flip the screen so our attending could see it. And then we were intubating direct, which is kind of an interesting thing. So even though I'm, you know, pretty versed in video, I learned on hyperangulation and not the geometry, which it sounds like this was certainly in favor of.
All right, let's get into the discussion. So Marco, one of your big points that you brought up as we were peer reviewing this was their primary outcome of first pass success. So let's talk a little bit about that. So what do you think about that as a primary outcome, and what do you think are some of the issues with that outcome?
Yeah, I think we really don't have a choice when we're talking about these types of device trials because you have to be able to pick something that's going to allow you to compare it to the other previous trials. So first pass success is that, because it's basically what they look at in every similar type of trial. So it gives you a comparison. Technically, first pass success is a disease-oriented outcome. We do know that the worse you perform in first pass success, the more potential harm you could be exposing to the patient. So to a degree, it's a surrogate for a patient-oriented outcome, but it's technically a disease-oriented outcome.
And for people who have problems with this, and I'm not saying you have a problem with it, Marco, but it seems like most of the issues we have with intubation happen when the patient starts getting hypoxic as we're trying to get the endotracheal tube in the trachea. And so what I'm saying is you have to pull the laryngoscope out and then you have to reoxygenate the patient. That seems like a good timestamp or disease-oriented timestamp for when we see a lot of these issues. And so I actually don't have a problem with this, even though it's kind of disease-oriented and a surrogate. But another problem I had that we brought up in the limitations is we don't have a lot of important information, despite that being the primary outcome of first pass success. And I wanted you to talk a little bit about what was some of the important information that we just didn't have that you absolutely have to have if you're talking about an intubation trial.
Yeah, I completely agree with the point. I think what you're alluding to is this 2-minute time frame on the secondary outcomes is somewhat problematic to me. And 2 minutes is a really short amount of time to see some of these things. So in my mind, when I see that, it's like, well, what is going on with this patient that they are becoming so hypoxic within this 2-minute time frame, or they're dropping their pressure? And we really don't know, one, what medications were given to these patients. So were they induced and paralyzed with succinylcholine or rocuronium, or were they given etomidate, or were they given ketamine? And that's a whole different debate we're not going to get into now. But all these medicines have different pharmacokinetic profiles and are going to be more prone to hypotension and different characteristics than others. So I think what medicine they received is pivotal to determining whether or not those medicines could have contributed to this hypotension or hypoxemia. The other thing I think they didn't really mention is what mode of pre-oxygenation. I think that's, again, more of a surrogate. If somebody's getting a 10-liter non-rebreather or a few liters on nasal cannula, that's not quite the same thing as getting BiPAP. So that tells me that if somebody is so sick that they're requiring BiPAP prior to intubation, then perhaps they're at a higher risk for getting hypoxic during that procedure. And that's more likely to whatever disease is causing their requirement for intubation, and not necessarily the type of device or medicine given per se.
So Will, you brought up the operator issue that we talked about. And so again, we've stated this is like the third time I'm stating it. Majority of the intubations were done by either residents or fellows. We got that. And most of them had 50 prior intubations. But what I want you to kind of dive into is they also looked at residents and fellows based on number of intubations that they had, like less than 25, between 25 and 50, and then up to 100. Was there a trend there that they noticed in this study that's worth kind of bringing up?
Yeah, so essentially we have kind of three different categories. It's less than 25% had been performed via video laryngoscopy, 25 to 75%, and then above 75%. So of the people who did video laryngoscopy, over half, so about 56% hit that 25 to 75% that's where they were experienced. Whereas it's kind of the same for those that got pegged with the direct laryngoscopy. 60% of their intubations had been from experience with video. So really, if the average is around 50, they've only intubated someone 25 times with direct, and now they're trying to do it on hopefully a first pass potential, and I think that can be kind of problematic, and again skew the numbers one direction. But regardless, it does show that the population of operators are significantly more versed in video. With I think it's probably close to 95% have had over 25% of their intubations be video laryngoscopy.
Yeah, and one of the things that came up was the view that they were able to get, right? This Cormack-Lehane grade. And did they notice a difference when they're talking about these residents and fellows intubating, whether they used VL versus DL?
Yeah, so actually there was a pretty significant. So grade 1 view was achieved 76% of the time using VL, compared to less than half, so like 45% direct. So again, that skews things significantly in the direction of video.
And then I want to talk a little bit about preparation here, if that's okay with you guys. So, to ensure successful intubation, we have to really plan, right? And I think this is something that we don't always do when we assume an airway is going to be easy. But I think it's important to have a plan A, a plan B, and a plan C. And I think you need to be facile in both plan B and plan C. Obviously, your best attempt is going to be your first attempt. But if you never practice plan B and you never practice plan C and plan A fails, how do you expect plan B or C to bail you out? And so that's my issue when we get into this debate of VL versus DL. I think the answer is already pretty straightforward, and we'll get into that when we talk about conclusions. But I think it's important to have other airway techniques that you feel facile with. And one of the questions that came up in one of my social media platforms is, well, if we're supposed to do VL on everything, then how are we supposed to get good at doing DL? And Will, I think you alluded to this during COVID, but there are laryngoscope blades out there like CMAC and McGrath that allow you to do both VL and DL in one. And you can literally turn the screen around where somebody can still watch what you're doing, but you can actually work with DL. And so for me, what this answers is not the standard versus hyperangulated geometry debate, which I have my own thoughts on, but it's there are better laryngoscope blades out there that allow us to do both so that we can practice B and C in terms of our plans. Do you guys, either one of you, have thoughts on that?
Yeah, I would agree with you 100%. I think that just like you, Salim, I'm actually EMI. I'm also, I think we probably trained around the same time. So we really didn't have the opportunity to train with video because it just wasn't accessible or readily available. But I find that compared to my own training, that you just have so much more latitude when you're in a training facility and you can see exactly what the resident is doing. You really give them the opportunity because you know, okay, they're right there. Plus, you can give them direct instruction. Okay, these are the bottom of the cords. Pull back. You're a little bit too anterior or something. So really, without being able to see them to see the cords and see the anatomy for the patient on the monitor, it's difficult to give that feedback instruction. And what you're more doing, or what I recall, is just somebody standing over your ear, over your shoulder. Do you see the cords? 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 It's like, this is a difficult procedure, high stress, potentially life and death. The last thing you want is somebody kind of micromanaging you in helicopter parenting per se while you're trying to do this. So seeing that video screen in front of you, it really allows the attending physician to have comfortability knowing that you're in the right position. And again, they can give you that feedback and instruction if you're doing something wrong. And if they need to jump in because you're just so far, in left field and you're not in the right direction at all, then they know, and they can do that when they feel it's necessary. So I'm heavily in favor in a video laryngoscopy with either a standard geometry blade. That's again CMAC, that could be McGrath, or that could be that glide scope with the standard geometry blade.
Yeah, I certainly agree. I think video is the way to go, but I think just as importantly, if not more importantly, is to have those A, B, and C options and have them every single time. Even if this is, you're going to do an intubation where maybe the patient's in like rapid CHF and you know that they're probably that's what we're going to go down, but we're going to go ahead and try BiPAP and something first. Having that A, B, and C every time, regardless of the intubation, how easy or difficult the intubation is, I think is what's really important, because for as frustrating as it may be being micromanaged, trying to shove a tube down someone's throat, if it's 3 a.m. and you're the only doc in-house and there is no one to take over for you and there is no one to help out with pointers, you need to naturally be able to go from A and say, this isn't working, now I need to go to B, now I need to go to C. And so having, video being your first shot, I think that's a great thing, but then not being afraid to take a step back and then maybe move to the bougie, which also, they did quite a few times in this study, and it seems like it helped quite a bit. But to be able to have that regimen, I need to go from 1 to 2 to 3 to the next thing, because trying A every single time is only going to, damage it more if it's not working. And so then it's time to move on to B and C.
And Salim, I just want to highlight again that I think really the important thing is, or one of the important things to know is that vast majority of the time, I think video is going to be fine, right? There's not really a huge difference because you're going to see the airway is going to go okay. You're not going to have any secretions or vomit or blood in there. But like you alluded to, you need to plan for A, B, and C. So you really don't know 100% certainty that this person's going to have a bloody airway, or you're going to paralyze them and they're going to have a belly full of blood or a belly full of vomit, and they're immediately going to start vomiting. And those are not the times where you want to use video or where video is going to be helpful. A bloody camera is not going to make it easier for you to get first pass success. And you have to prepare for these situations so that when you're in them, you know what to do and you're not afraid, and you know how to handle it. And they don't happen often, but I can think of a handful of times in my career. The most difficult intubations are the ones, these upper GI bleeds that get intubated and all of a sudden they just start vomiting a belly full of blood, and the camera's just not going to be able to help you in those situations.
Yeah, 100%. So here's what the authors concluded, guys. Among critically ill adults undergoing tracheal intubation in an emergency department or ICU, the use of a video laryngoscope resulted in a higher incidence of successful intubation on the first attempt than the use of a direct laryngoscope, close quotes. So Will, what is our conclusion? And then Marco, I'm going to have you give us the clinical bottom line.
Yeah, so I think when it comes to video versus direct laryngoscopy, there's definitely a higher association of first pass success with video compared to direct. These operators were a little less experienced because these were basically trainees or fellows that were more experienced with video laryngoscopy. But I think nonetheless, the video laryngoscopy offers advantages. So you can visualize anatomy, which is going to help with your first pass success. And then it's also going to help those people, the other operators in the room that might be able to offer some encouragement, see the same thing that the intubator is seeing.
And Marco, the clinical bottom line?
Yeah, Salim, bottom line, we recommend video laryngoscopy with a standard geometry blade, and that's whatever device you want to use, the McGrath, the CMAC. These devices allow for a seamless transition to direct laryngoscopy if you have an unexpected complication like a bloody airway. Additionally, using VL allows and provides the resident physician a lot of latitude because we know the attending is going to be able to see what they're seeing, and they can give them that direct feedback to make sure that the patient is safe and they're providing the proper supervision to that resident trainee or fellow.
And there you have it, Rebel Am listeners. Leave us your thoughts, comments, and questions. Thanks for tuning in, and until next time.